to 10,000, then this would be 1 milligram, and 10 milliliters equals 0.5 milligrams over X. So now X would equal 0.5 times 10. And that would equal 5.
Okay, thank you.
So that's how 5 milliliters. So, that's how you would determine what to do. So what it actually kind of tells you how to set up the formula, but I'm just presuming there was a zero missing in what you placed in the chat. Would that be a fair assessment?
Yes.
Okay, so that would be how you figure that out.
Okay, thank you.
You are welcome. And go back here. Okay. All right, so let's talk a little bit about TB. And with TB, we're going to talk about why people get it, where does it tend to house the most. We're going to talk about treatment and why treatment definitely should be, it's a lot of teaching with that because patients are going to be on a bunch of meds. And then we're going to move to that to our either lupus or RA, but I'll talk about the differences between the two. There's some crossover between the two events, but they happen differently and affect different portions of the body. So let's share screen, go back to the paint board. And again, while I'm in the paint board, I can't see what you're saying to me. I'm so sorry. But just, chime in, raise your hand and say, I have a question, and we'll just move on from there. Okay. So with TB, is this contagious or non-contagious?
Highly contagious.
It's contagious. It's highly contagious. And it's so contagious, and it's really weird. And it's from droplets, right? So when you cough, it could be when you talk, definitely when you sneeze. All of those things can lead to the spread of a person developing tuberculosis. What ends up happening is that the droplets get suspended in the atmosphere or in the air. Whereas, because is this a big or small bacteria? Big or small? I need you to answer. I can't see the chat.
Very small.
It's very small. Okay, so here when someone coughs or talks or sneezes, I mean, literally that droplet will just stay suspended, and then some, some poor person comes by and they may inhale that mycobacterium, which is completely different than your other bacteria and viruses, because they don't really stay in the air because they're larger. So they'll usually drop off to the ground or surfaces or whatever may be around them. So for sure, we need to do droplet precaution, right? Airborne and droplet precaution. So what should a healthcare provider to prevent themselves from being catching tuberculosis while treating a patient that has active TB? What PPE should they have on? Go ahead.
You should wear droplet precautions, N95.
Yeah, N95, or the HEPA filter mask is another name for it. HEPA filter. They're definitely going to be on droplet and airborne precautions. What else?
Negative pressure rooms.
Yep, they need to be in a negative pressure room. And all of your PPE needs to be outside the patient's room, which if they do have all negative pressure rooms are set up like that, you have a room for you to don your gloves and so forth and so on and take them off. So you need to make sure you do have gloves, goggles, gowns. So just, just in case we forget about that. What if your patient needs to leave the floor? So if the patient needs to leave the floor to go to CT scan, what should we do for the patient?
Put a mask on them.
What kind of mask?
Surgical mask.
They need a
N95.
surgical mask.
Yeah.
No, you get the N95, and this is the reason why I'm covering it, because a lot of people will put the N95 on the patient, but it does absolutely nothing. It just allows for the germs to escape out. So what you're doing with the N95 mask, the filter is in the front to prevent the bacteria or whatever to get in. So that's why providers need to have the N95 mask on. Your patients, if they go to CT, then they need to have, or your clients, they need to have the surgical mask on. So that when they're traveling through the hallways and things like that. All right. So let's look at, the bacterium is Mycobacterium tuberculosis, right? That's our bacterium of or bacterial problem, or the problem cause, or problem child, or however you want to put it. And some of the risk factors, let me change that to an R. Oh, Lord. Some of the risk factors that are involved with, for a person developing TB. What is the risk? So what's our etiology? Who's our most susceptible folk?
Immunocompromised patients.
Awesome. Our immunocompromised. So like your HIV, people with a low immune system, could be your diabetics, people on chemo. So that would be a type of an immunocompromised folk or patient population. Who else? What are our other risks?
People who live in close quarters.
So close quarters. So if you work or live in close quarters, and you could say close or tight. So basically you're literally on top of each other. Then they are more susceptible. So you would see things like prison. That'd be a good place. I'm having a brain infarct. This is from no breakfast. So don't do that. So prison. What about your long-term care facilities, your LTACs? They're in close quarters, your nursing homes, your homeless people. If they stay in the same area, so they're kind of more susceptible. Anybody else? What other folks?
Healthcare workers.
Healthcare workers. Yep.
Alcoholics and IV drug users.
Okay. So substance abusers.
People from other countries.
Okay. So that would be your immigrants, right?
Also, people who live in urban areas, like large cities.
Okay. You can live in a large city, you talking like Dallas, is that what you mean?
Just like urban areas where it's like heavily populated and a lot of people are coming.
Yeah. New York City, that would be a good example. So all of those, yeah. People that have, go ahead.
Age?
Yes. Age definitely plays a role, and especially if they are less than 5, your kiddos and your elderly. And we're going to talk about some of that too, status. And then kiddos less than 5. they are more susceptible because their immune system is still weak. It's not fully developed. So they will have more issues. So if there's a person with tuberculosis, or if you have a patient with tuberculosis, how would you know that they may have potentially been exposed to somebody with TB? And this would not be someone that would be in the healthcare system.
You would ask assessment questions?
Yes, so we need to ask some questions. You need to ask a bunch of questions. And sometimes people don't really know, where it actually came from. But, we want to ask about travel. We want to ask about visiting people in long-term care facilities that may have tested positive, even if they knew it or not. Have they visited anyone that's been incarcerated? And even if they didn't visit, it could be somebody else that may have visited somebody that was incarcerated, but they came in contact with that person. So it may have been, 2-3 people down the line before it actually got to them in reference to them, being exposed to that individual. Okay. What else? Anything else? Any other questions we want to ask? We said historical questions. So what other historical questions could we ask?
If they had any
previously had TB.
Okay, they previously had TB. Okay, I like that. Go ahead.
If they're an immigrant and they've received the BCG vaccine.
Okay, so let's talk about the BCG vaccine and what that is. So the BCG.
What?
Uh-oh. Can you mute yourself if you don't mind? If your baby's calling you. The BCG vaccine is called the Bacillus Calmette or Calmette Guerin. And they give that to folks to prevent them from developing TB. However, when they get their skin test done, and what's the name of that skin test that you guys have to do? So the PPD. The PPD. So when they get the, go ahead. It's the protein what?
Purified protein derivative?
Yes, purified protein derivative. That's what that stands for. They're going to have a false positive. And the false positive on their skin is due to the fact that they've already been exposed from the vaccine. So for this individual, we can't necessarily go with the false positive. They need to go ahead and get the chest x-ray. Okay. So that BCG, and you will ask if they have the BCG vaccine. And then anticipate. Hey, can you please mute yourself? I'm so sorry. I don't know who that is, but please mute yourself. So they'll have a false positive, and they'll need to have a chest X-ray done. Okay. So for folks that are not immigrants, they will do the PPD, or the Mantoux test, and then it needs to. They're going to get the right underneath the skin layer, right? And when they get it, it should have like a little bump to it, right? Because this is the skin. It should have a little bump to it. But we need to have it read within how many hours? Go ahead.
72, 24 to 72.
So 48 to 72 hours is when it needs to be read. And what we're reading is we're looking at the end duration of where the PPD was done. It should always be done on the inner forearm. And there's plenty of space for that to be, for it to actually, go down. So when that 72 hours is up, or 48 hours is the earliest that you could get it done, then we're going to be looking at, as I said, the end duration of, and what I mean by end duration, what does that mean? The hardness of it, the size of it, the height of it, correct?
The swelling or the height of it.
So we're looking at the height of it, and we're going to look at the width of it. We're going to see how big this is, okay? So in your book, it talks about what a positive skin test would be. So if it's greater than 15 millimeters, it's always measured in millimeters. So if it's greater than 15 millimeters, this is considered positive for everybody, no matter who you are. Go ahead with your question.
I read that if it's greater than 5 mm, it's a risk. So.
Well, we're getting to that.
Okay.
Okay. All right. So, so if it's greater than 10, then this would be positive for immigrants, substance abusers. So that would be your alcoholics and your IV drug users. And then people that live and work in close quarters. And for kiddos, less than 4. All right, so if it's greater than 5 millimeters, then this will be for your patients that are HIV positive and that they've come in contact with a TB patient. Organ transplants. And a person with an immune or that's immunosuppressed. So that would be the individual, yes. Go ahead. Do you have a question?
I'm trying to get the mic to work properly. Just keep blocking me. I'm sorry.
Okay. Did you have a question?
Pretty much, it could be like a cancer patient, which is a 5 millimeter. That'll be like the okay. That's all I need to know.
Did you say and HIV too? Because that was the first one I wrote.
Cancer patient.
Yeah, that'll be anybody that's immunosuppressed. Whatever their whatever makes their body immunosuppressed, whatever condition they have, then that would count under that 5 millimeters and above. So between 5 and 10, and then between, if it's 10, between 10 and up to 15, or then that would be considered for those people and the immigrants and substance abusers, and everybody else. If it's above 15, then you are for sure positive for tuberculosis. Or you're not for tuberculosis, but you're positive for the for exposure. So you've been exposed. We don't know yet. So the positive PPD does not equal the fact that you have TB yet. You now need to do a chest X-ray or a sputum culture. So we need to move to the next step to verify whether or not the individual does have active TB. The PPD or the Mantoux test basically tells you that you have been exposed. So what that positive result means is that you have been exposed to PPD and to TB, but not that you have it. So this means exposure.
If it's less than 5 millimeters, is that negative for everyone?
That would be considered a negative unless they had any other symptoms that, and we'll get to what those are, like the coughs, the night sweats, unintentional weight loss. If they're having those types of things, then that would be looked at. Next question.
Would latent TB show positive?
We're getting ready to get to that. Just hang
Okay.
on a second.
Okay.
All right. So questions just about how to read the TB skin test. Okay. And what the VCG and how that plays a role. All right, so the next question that just came through was about latent TB. So let's talk about that. There's two processes for TB. So you can either have latent or you can have active. Yes.
Hey, just a quick question. Sorry, whoever is calling in, can they mute their phone who's just called in? Because I can't hear you. You keep breaking up.
I'm so sorry. Please mute your phones. Please mute your computers unless you are asking a question. Then unmute yourself, ask your question, then remute yourself back. Is there anything you needed me to repeat for you?
No, thank you. No, thank
Okay.
you. You're doing good. Thank you.
Okay. Okay, so the question came up about latent TB. So you can be exposed to TB, and if your immune system is good, then you will never, I won't say you will never, you will not immediately develop active TB. And I'm going to use immediately. So here you have a positive exposure, but you don't become active. And that's because your immune system is strong enough to take care of that bacteria at the time. Okay, so you have a strong immune system. Do you have a question? Or someone, I don't know if your hand is raised. Go ahead.
You're saying pretty much that person is just colonized.
Right. So I'm gonna talk about the whole situation. So basically, if you have a strong immune system, then you may not develop. Your body may be strong enough to actually wall off that bacteria. So it will surround it or encapsulate the bacteria. So here, the body or the immune system will encapsulate the bacteria. So say for instance, this is your bronchial tree. So, and I'm just drawing something, don't take offense, I'm not an artist. And so say here, the bacteria was here and here. So what your body would do is it will come in and it will literally surround it. And it'll just basically close it off to the rest of the lung tissue. Does that make sense? So now it's encapsulated. And so now it will sit in your body system. Now your test will be positive. Your PPD and your blood test will be positive because you have been exposed. That's the first line. You have positive exposure. However, you may not develop the active form of TB because the body will keep it dormant. So all the way through your body, the bacteria is still there, but it just lays dormant.
Yes. So if you have a latent TB infection, do you have that for life?
Nope, let me finish and then it'll answer all your questions.
Oh, okay.
Okay? All right. So while it's laying dormant, it will lay dormant until your immune system becomes weak. So when your immune system becomes weak, then this encapsulated bacteria will now be able to escape and come out. And you can see that here. And so now the patient will develop they will now develop active TB. So your latent form now becomes active. So your body holds on to it until the immune system becomes weak or the person gets HIV. Either way, now the person's compromised. And so now this will become active. So the entire time that they have latent TB, the individual will still test positive for the Mantoux test and the PPD. So I'll put here that they'll have so in the latent phase, their PPD is still positive, the blood test is still positive, but their chest x-ray is going to be negative. Their sputum, what do you think if they did an acid-fast bacillus? Their sputum, would that be positive or negative?
Negative.
It's going to be negative because prior to that, it was walled off. It wasn't active. So once it becomes open, like I just kind of put a break in the black line there, then as long as it's closed, then this is what you're going to have. Then when it becomes active, then things are going to change. Okay. So the next question is, should they be treated? So even though they have the latent phase, should they be treated?
No, because it could cause drug resistance.
Yes.
It's kind of controversial, but the book basically says they should be treated.
The active TB later.
So they treat them to prevent them from getting active TB.
Do they use chemo for latent TB?
No. They're going to use the appropriate anti-tuberculosis medications. So we're treating. Let me ask this. Are you asking about the chemo because of the person being immunosuppressed? Is that why you're asking about chemo?
I just read that chemo is a prophylaxis for latent TB.
I think what she was referring to is like the med isoniazid, the INH, that is a chemo med. I guess that's why you're saying that.
Yeah. Okay. When I'm thinking chemo, I'm thinking like those alkylating agents. I was thinking of those. I was like, I don't remember those. But INH, yes. Okay. So we're gonna get to all the meds, so just hang tight. But we are gonna treat them prophylactically because they've already been exposed to a person that has TB. So even if you don't have signs of it now and that it may be latent, they're going to treat you. So even because you've had the exposure, okay? So especially if there's somebody that they know that you've come in contact with that was positive for it, they're going to go ahead and ask you, they're going to ask you to do the prophylactic treatment to make sure that you don't develop TB. So when you have TB, you'll have all the signs and symptoms, and we'll talk about what that is here. So I'm going to scroll up so we can do that piece. So when you do have TB, then the signs and symptoms they're going to have is a positive cough for how long?
More than 6 weeks?
So at least 3 weeks or more. They could have chest pain. They could have hemoptysis. What is hemoptysis?
Coughing up blood.
Coughing up blood. Night sweats. Fever. Weight loss that they weren't intending to do. Fever, chills. Let me just put that here. So these are all signs and symptoms. They could have pain with coughing or breathing. Their PPD will be positive, as well as their blood. So if they do the blood test, this is going to be positive. Sputum culture will be positive on that acid-fast bacillus. And many people that develop active TB, they get it from latent TB. And one thing that's most people may not be aware of is that TB can spread to other areas of the body. Like what? What body systems could it potentially go to?
Spine.
So yes, it can go to spine.
The kidney.
Lymphatic.
Okay. So the kidneys, it gets to the spine, the kidneys, the brain, and all those other places through the lymphatic system. So that's how it travels to those other areas to affect the brain, the spine, the kidneys, even the joints. It can do. One of the main areas that you'll find TB in is, as far as the lungs are concerned, are in the apices, because that's where the majority of your oxygen is at the tips of your lungs, and they like that. They like the oxygen component to it. Does somebody have a question? Okay. So there are other tests that you can do. I talked about blood tests. What's the two blood tests that you can have done, or what are they called? One's the quantiferon TB, the gold, because that was one of the ones that we were required, or we have as an option to do, is the quantiferon B TB gold. You can do the interferon gamma release assay or the T-spot. Do they tell you if the patient has latent TB or if they have active TB? Can they tell you that?
Yes, the gold can detect.
What are these tests telling you? They're telling you that you've been exposed?
Yes.
Okay, so it doesn't tell you if you have it. So all of these tests let you know if you've been exposed. You don't need to go back and have it read in 72 hours because it's a blood test. What is the best methodology what gives you that bird's eye, for sure that positive that your person that they do have TB? What test is that?
Either a chest X-ray or AFB smear.
Sputum.
It's the sputum. The sputum will tell you if the person has TB. It'll tell you if the TB disease is being treated appropriately, because less of those acid-fast bacillus cells will be present in the sputum. So you can get that from someone coughing up phlegm, or you could actually go in and do a bronchoscopy, but I don't think anybody wants that. But if you need to collect a sputum culture on somebody that has active TB, they usually do a sputum culture for a couple days. Then you should get it in the morning. And then you can do a chest X-ray. And on chest X-ray, it will show you the infiltrates that the patient will have on X-ray. So those things are available to you. So when you're reading that report, then that's what you would be looking for. What's standard treatment for TB? How many months will a person be on TB meds?
6 to 12 months.
6 to 12 months? Does that sound about right?
6 to 8 months.
Say that again. Okay. So there's 4 drugs that they will give. One is the isoniazid, which is the one, the chemo med that we were talking about earlier. Rifampin. Let me write those for you. Here. There you go. It's nice to have these little whiteboard pens, but I lose it every single time. I'm like, what did I do with it? And all right, so remember, you have to know the generic spelling or versus the brand name. So the first one would be isoniazid or INH. And then we have rifampin. And then ethambutol. And the last one would be, got those transposed. Yes.
A lot of the textbooks that I've read say that streptomycin is included in the first line meds as well. Would you agree with that or disagree with that?
I don't have streptomycin could also be used, so I don't disagree with the book. These are just kind of the mainstay, and that may be a new addition based on new research coming in.
Okay, thanks.
So you remember, Lippincott updates the book as soon as they get new information. So they will put it out in their materials. So I can't disagree with that. So if someone has TB at home, what would their wife be like at home?
Like our life is now?
Oh, that is true. Isolation. You can't go, no visitors, you can't go to school, you can't go to work, you can't be out in public. I mean, it's very lonely. So, you might want to also look at if a person gets depressed from all of that. Yes, I think someone had a question.
Yes, Ms. Hudson, on this particular disease, isn't this the only one that the individual is practically forced to be compliant with their treatments and stuff?
Yes. And, they need to do that because if not, you're basically infecting anybody that you come in contact with. So they have to abide by that. The only time they can go out is when they have a doctor's appointment. And then they got to wear a mask and all of that. And usually doctors will try to get them in, where there'll be the least amount of exposure to their patients. Because all they got to do is cough.
Yeah. Okay.
Or yell or sneeze or anything like that. And this is not going to be a good event. So, yeah, they need to be at home. They need to be isolated. And as much as it sucks, it just be what it be. Now, they continue to take the medication for so long to make sure that why do they continue the process? Even if they have negative acid-fast bacilli. So why do they have them finish out the course?
Well, because once it becomes latent again, right? So they would still need to get the treatment so it doesn't go back to active.
Okay, is that true?
It becomes resistant to the medication.
Exactly. It's more about the resistance. So it's just like any other antibiotic or any other medication. You got to take it all the way through. So that will be part of that teaching to make sure that even if you start feeling better, you still need to take the medication in its entirety. So you cannot just tap out on it and be like, oh, I'm done. I feel great. And I'm going to hold on to this just in case I get it again. No, you can't do that. Yes.
I had a question about, I know the patient's isolated, they isolate themselves, and I know we instruct the family that they don't have to be in respiratory isolation since they're already exposed, but does the family isolate themselves too, since they're exposed, or like, do they only isolate with symptoms?
Usually if they have symptoms, but they may be treated though, prophylactically. So they may be exposed, but if they're both being treated, then they should be A-okay to be in the same space together. Does that make sense?
Yes.
So you may not have the condition and somebody else may, but if you start treatment just like they're doing treatment, then you're already being treated. So if you were to develop something or to come in contact, then your possibility of getting the active format of it should be minimized because you're taking the medication. And if you do get it, you're still taking the medication to eliminate it. So it's kind of, it's best to do it so that way you don't have to be isolated, but you can still be amongst your family. Because if not, and say if you were a single person, then you would be stuck between those walls that entire time. And then you want to consider, someone coming in later on and probably doing a mass clean down, wipe down of all of your furniture and things of that nature. So that may be another thought process that they may want to consider after the fact. So that's the whole purpose of the prophylactic treatment, is so that the individual can still be amongst family folks and not be isolated completely. But it's still a bummer, even though, we're at home with family. And there may have been a point in time where you're like, I can't wait to be at home with my family. But now you've been at home with them for a good solid 2.5 weeks. And everybody just, you need some outside, some fresh air, different scenery. You need some different things to happen. So if the immune system, Fontana, if the immune system is weak, then what's going to happen with the latent TB, it will now, the encapsulated shell will become weak and release the Mycobacterium tuberculosis, and the patient will now develop tuberculosis. It's not that they will get HIV. Basically, anybody with a weakened immune system, so that would be an HIV person, it could be a homeless person. I have a weakened immune system because I have leukopenia. Diabetics have a weakened immune system. COPD patients have a weakened immune system. So it's just basically saying anybody with a weakened immune system, if you get exposed to somebody and you had latent TB, once your system is weaker than what your body's normally used to, then it's going to now allow the bacterium to be released out of that encapsulated shell that it was in. Does that make sense? Did that answer your question, Fontana? Okay. Did that answer your question previously that I was talking about for the person being isolated? So I hope so.
Yes, ma'am.
Okay. All right. Yes, Eunice.
Just to clarify, where did you say the bacteria loves to go in the lungs? Did you say the tips, the apex, the lower lobes?
At the top, at the apex.
Do you mind writing that down? Because I don't know how to spell that.
Oh, no, not a problem. I can do that for you.
Thanks.
You're welcome. Let me go to paint. All right, so it can be in the apex. So if this is your lung, right, it's going to be up here. It's going to like this area all up here. Because that'll be close to the scapula.
Okay.
So, all right, the antibiotics would be your second line drugs that you would use. And you, as again, we talked about before, that you need to be on the therapy for at least 6 months. And they could either do daily doses or weekly doses, but they're going to be doing some doses. Okay. They can do streptokinase or streptomycin, not kinase, streptomycin in some cases. They can do those if the as a first line treatment. Other medications could be levofloxacin, so that's another antibiotic. Those are alternative medications that help with respiratory infections. Moxifloxacin, so they could either be on that as well to help treat TB. Meropenem, that's a very good antibiotic that they use for a lot of other respiratory conditions that patients have, even pneumonia and things of that nature. If it's significant, they may end up having to get a lobe removed, which we don't want to have happen. Other therapies that we can do is make sure that, we're meticulous in how we handle patients. We're not doing any cross-contamination. We're not using our own personal stethoscope. So there's usually one disposable stethoscope that is assigned to the patient's room. And so we should use that and make sure we wash our hands before and after. And taking care of these patients means you have to cluster care, which means you need to think about how you're going to deliver your morning care to the patient or your afternoon care or whatever it is. But all your encounters that you have with the patient be clustered. So you shouldn't have to go in and out and in and out. So if you're actually doing morning meds, and you need to make sure there's fluid in there, or they have something to drink with it, or if you're doing it IV, you have all your flushes, you have all of your alcohol pads, because you don't want to be digging into your pockets, your uniform, and then taking that home with you. So just kind of things to think about. We also need to make sure they have good nutrition. When time is available, they're going to need a high calorie diet, and make sure that, we can help promote and support healing. We wanted them to talk about things that are bothering them with TB, because, it does have a little stigma attached to it, and some folks really can't. It's a lot to encompass when you have that. Anything else you can think of that we should help with the patient? We're going to do INOs. We're going to check liver functions tests. So there's a lot of things there we're going to do. Any other labs do you think we should look at?
CBC, since the INH does often cause bone marrow suppression.
Correct. So we want to look at the CBC, and we want to look at that in the beginning too, to see if there's an infectious process and see if their white cell count is up. And normal white cell count is 5 to 10,000. So if it's at 15,000, then this is well developed, right? What else can we look at?
The BUN and creatinine.
Okay. BUN and creatinine, those will be good.
You said
Go ahead. What were you going to say?
You said, do we need to talk to the patient about the things that is related to TB, or avoid us talking about it?
I mean, you would educate your patient on, you would try to isolate where you think the exposure could have come from. Let's start with that. And then you could, I didn't realize that happened. Then you would talk about, making sure they stay safe. Within about 4 weeks, they should start to feel better and be able, and they're not considered not to be infectious, but that's still going to be determined by the physician. So that's kind of a guide. But we want them, to talk about what's bothering them in having tuberculosis, because if you have to be isolated and the stigma that's attached to it, people may become depressed and isolate themselves, but not necessarily isolating themselves because of the TB, but now isolating themselves from a withdrawal. So I'm just saying, consider the psychosocial component to it as well, not just, hey, you got TB, figure it out when you get home, but just, kind of give them an idea of what their life is going to look like for a couple of weeks or a couple of months, and how to, keep their immune system up, and how to make sure that, you don't know who has TB, but I mean, you could have been walking in a grocery store and somebody could have sneezed and had been exposed to somebody with TB. So, I mean, it's not their fault that they're got it, is basically what I'm saying. But when people are, oh my God, you got TB, ooh, and then they start acting all berserk and crazy. And that means the people who don't have it. So just, have a conversation with them to provide that teaching on, making sure they take the medications as prescribed. If you start experiencing, lull periods and this is starting to bother you, talk to somebody, get that help that they would need. So I'm just kind of addressing that component. Doing breathing exercises, and spirometry, and practicing those things to help the lungs get better. Liver enzymes, CBC, acid fast bacillus. Those are all the types of things that, they have to do that sputum test. So they may be delivering sputum tests to the physician's office on a regular basis until, those numbers or those stains go away. That's what they're going to be looking for.
Thank you.
So the question Alexis has is, I know that the BCG vaccine can cause a false positive. It causes it for both the skin and blood. So if they've already had the BCG, because what it's basically saying is, unless they're doing the quantiferon, but what it's basically saying is that they have been exposed. The chest x-ray would show lesions if they have active TB. So if they do not have active TB, the chest x-ray may not show the walled off encapsulated bacteria, but a CT might. Yes, Eunice.
I know you say that latent TB shows a positive PPD. So how would you determine if it was a vaccine or it was a?
You're gonna have to ask if they got the vaccine. So so ask them if, and that was the question we talked about earlier. When you're asking questions about travel, you're asking questions about have you been in long-term care facilities, visiting people that have been incarcerated. So you're asking those questions. Have you ever received the BCG vaccine? So you're asking those questions. Some people may not be an immigrant, but they may have traveled to the country and got the BCG vaccine. Does that make sense? So you're asking them in advance when you're getting your history and doing your assessment, your initial assessment of the patient in the first place. Now, if that question's already been asked, then you don't need to re-ask it. But if this is the first time you're seeing the patient, then you want to look at things that could have caused them to be exposed. Were they had high-risk behaviors, substance abuse, alcoholics, tight quarters, living in a shelter? So you would be asking those things up front. Homelessness, to see if you can identify the issue. Did that answer your question?
Yes, thanks.
Okay, you're welcome. So, any other question about TB that's burning through your mind? Does that answer all of all the questions that you have needed?
Somebody asked about riverpentin on the chat.
Okay, let's see. What about, is that not considered a first line med? Isn't that the same? And I just want to make sure I'm not thinking the wrong thing. Is that they're using rifampin versus the rifampicin instead of that one? Because you're talking about Priftin. The other name for that was Priftin.
I think they're different because rifampin is different.
No, they're
so
different.
You one or the other.
They're using more rifampin. So we're going to go, even if in practice they are using the Priftin, we can only go with Lippincott for right now, because that's what our gold standard is.
Is there a specific, sorry,
Nope, go ahead.
is there a specific way to tell the patient or educate them about disposing their sputum or other body secretions if they have TB?
To educate them about the sputum, or
Yeah,
like,
like how to dispose them if they're at home to make sure it's not, other people doesn't get it, if they're not exposed to it.
so if they have a patient at home, if your patient actually has TB, and so you're asking, how do you educate the other folks?
Not the patient, to make sure they're protecting family members and how to dispose their own sputum and like other secretion if they have like body
Right, so
secretion.
you want to tell them that you don't want to have them coughing in the air. They should wear a mask. They should wipe down toilet seats and things of that nature. If at all possible, let that individual use that one bathroom and everybody else use something else. So those are things that you can actually navigate through and tell them that surgical mask is what they need. But remember, those folks will probably, if they have a family member at home that's been exposed, they're going to be treated prophylactically. So they all need to be wearing masks. Does that make sense? The
Yes, thank you.
wear masks so that way you don't keep cross-contaminating each other. But they're going to be on anti-tuberculosis meds as well.
All right, thank you.
Okay. I've read that you need 3 positive results to confirm TB type diagnosis. Sputum positive MANTU. Okay, so the MANTU basically tells you if you've been exposed. If you're looking at the sputum, they will take sputum for the first 3 days, and then they'll continue to monitor that as needed. But you need to have 3 negatives in order to be clear. Does that clarify for you, Rachel? Okay. Are there any medications that are resistant to TB? There probably are. All medications don't work, which is the reason why these 4 have been listed as the top 1. So, and when you eventually get back to clinical, this is how you will know if a particular antibiotic will work for a patient's condition. You need to look at the sputum culture, the final results. In those final results, they're going to have a list of antibiotics. So when they get the sputum, they find out, hey, this is the bacteria that it is. Then they take that bacteria and then they put it on antibiotic media. And then they look at which of these medias had the most inhibition of the bacterium growing. So which one did not allow the bacteria to just flourish all over the Petri dish? That's what it's looking at. So it'll tell you which ones are not going to work for it. So that way you don't prescribe the patient that particular medication. So that kind of work outside of research saying that these things work the best. But they also look at that piece as well to see if this antibiotic is going to do the job for this patient. Then they're also going to look at, did the patient have any renal issues if the medication is excreted through the kidneys, or however it's going, or do they have any liver issues if the medication is going to be excreted through the liver. Then they make some adjustments based on that. Okay. Did that answer your question, Jennifer? All right, I'm going to move on to Caitlin's question. Would the BCG give a false positive on the sputum test too? No, because the sputum tests whether you have the bacteria. So if you have the bacteria, that means you cough it up, it's in your lungs. If you have it, then you're going to have, it's going to stain red if you actually have the Mycobacterium tuberculosis. Or would you even do a sputum culture if you know they were vaccinated? Okay, so if you know they were vaccinated, if they have signs and symptoms that could potentially be TB, you would do the sputum test just to rule it out. So they may do that. Are prophylactic medications started on patients who have risk factors of exposure to prevent latent from being active? So, Paris, so are you asking, is this person with somebody or have been exposed to somebody that they know that has TB? Because if that's the case, then they would be on prophylactic medication. So right now, if you are not going to be around the person, if you don't have any signs and symptoms, you have a positive skin test, you get a chest x-ray and it's negative, then they're going to let it go. But if your family member that you hang around on a regular basis, then, and they'll say, hey, you have active TB or what, or that patient has active TB, then they're going to put you guys or whomever, the folks that it's going to be in that immediate circle in those tight, close quarters, that person will be on prophylactics. So does that to prevent them from developing active TB. So does that answer your question, Paris? Okay. All right. You are welcome. So we're down to the last 2 minutes, and I did want to get to the SLE and talk a little bit more about the rheumatoid arthritis. So I'm just going to throw out an option to you. I can make myself available to you guys to do a Zoom session. I don't know what you would have to let me know what your availability is. Right now, my best open time is on Saturday morning from 10 to noon. Does that work for you guys? Okay, so
Can you repeat that, please? I couldn't hear you.
Okay, so what I said was we have 1 minute now left in class, and with the 1 minute left in class, I won't be able to talk about the RA, and I did send you some case studies, and I really want, and they're shorter, and I wanted to go over those too. But I can make myself available to you guys Saturday morning from 10 to noon, and on Zoom, and I can send you the link. And then post it. You, whether you know it or not, you have a YouTube page. It's DCCCD-S1, and so any Zoom sessions that I record for the students is posted there, and you don't need to join or anything like that. But it's on YouTube, and that's where I usually post those when I do them. So that's your YouTube channel page. So I will send you all the link to the Zoom session. What about the test? Which part about the test? The test is Monday. It'll be online. I will be sending out the information for exam ID for you guys to set up your profile. So that way you can get it completed and then try to have it done by tomorrow. It is a practice test. It doesn't count. It doesn't mean, it's just for you to experience being, using the Exemplify's new system. So don't, there's a practice test. It's like 5 questions. It's nothing big. I promise you. I will not set you up for the okie doke, but it's just for you to understand how that system works. So that way you're not in the test and then having a freak out moment. So that's the reason why they do that. It's simple. I kid you not, guys. Don't get all bent over it. Yes, Fantana.
So we have clinicals on Monday, and they said they're going to change the test for Tuesday.
Right.
Is that true?
That is true, but it was always that way. Miss Perkins and I had already worked together in the beginning of the semester for her clinical group. So that clinical group will take it Tuesday morning at 9, just like it had been originally scheduled.
Okay, so you said we have practice exam?
Everyone's doing it. Every level is doing it. First semester's doing it. Second semester's doing it. Fourth level is doing it. Everybody is doing it. So everyone's doing it. All it is to get you set up on Exemplify. It doesn't, the grade, it's not even a grade. It doesn't even count. It's just for you to learn how to navigate through this new proctored system. That's all it is. That's why I said it's not serious. So don't be all up in arms about it, because it's just, for you to learn how to navigate the system. that's all it's about. There's not a grade attached to it. It doesn't mean anything. It's just so that your profile is up there. You're just setting up your account. That's what it is. I'm going to make that available to you, Aisha, later today, and you'll have up until tomorrow night to finish it. Stephanie, off topic for clinical, will our cam be on the entire time? No. So I answered that earlier. It would not be on the entire time. You will be online the entire time. You're going to have work to do. So